And so, touching on depressive disorders, we won't be able to go over each one of these in detail today. Disruptive mood dysregulation is a childhood disorder, so it's not. This diagnosis is not given before age 6 and it's not given after the age of 18. And so we'll cover that disorder more when we get into the childhood disorders lecture. Major depression we will be touching on today in much more detail. Persistent depression is depression that, as the name implies, persists for at least 2 years, and it's also called dysthymia as well. So if you're wondering about those two words, they're sort of used interchangeably for the same condition. We also won't touch on in detail premenstrual dysphoria. With this diagnosis, this is it's in females, and it's symptoms that occur the week prior to the onset of menses, and then they start to improve the few days after menses. So we won't touch on that. That's a relatively newer diagnosis, and certainly when diagnoses get added to each edition of the DSM, it certainly increases the research on that, and so I'm sure we will begin to know more about how common, prevalent, disabling this disorder is as we move forward in the years to come. So we won't be touching on other depressive disorders either, because as I said, there's just too much content to focus on to be able to get through all of them. But I just want you to be aware that there are a number of other categories of depressive disorders, so whether it's related to a medical condition, so in my area where I work with people with chronic pain conditions, definitely comorbid depression with chronic pain is very common. Trying to tease out whether depression contributed to the chronic pain or whether the depression is because of the chronic pain becomes difficult, so this one depressive disorder due to a medical condition is tough to differentiate, but it's certainly a useful knowledge to have in terms of assigning that diagnosis so that then treatment can be guided appropriately. Also, substance-induced depressive disorder, other specified depressive disorders and unspecified. As I said, we won't be touching on any of those in detail here, so you won't need to know details on those for this course or for the quiz, for example. So today we will be touching on major depression disorder. And so with this disorder, have to have the presence of at least one major depressive episode, and we'll go over exactly what the criteria are for a major depressive episode. And we have to rule out other disorders so that the symptoms are not better explained by schizoaffective disorder, for example, or these other disorders listed here. And one of the key distinctions is that the person cannot have been diagnosed with a manic or hypomanic episode. And so what we're looking at for a major depressive episode, whenever you're trying to figure out differentials, there's some key details that you want to hone in on. So you want to look at the number of symptoms or signs and symptoms that are needed, and also the specific time period. So if you don't have the cluster of symptoms happening in the same time period, it won't meet the criteria. But if the cluster of symptoms do occur in the same time period, then you're meeting that diagnostic criteria. And so here for a major depressive episode, we need 5 or more of these symptoms in the past 2 weeks, so it has to be in the same 2 weeks, and it has to represent a change from previous function. And among those 5 symptoms that are present, at least one of them has to be either depressed mood, so this first one, or loss of interest or pleasure in activities that were previously pleasurable. And then along with that, you can begin to see why depression, as with other disorders, is such a heterogeneous presentation. The 2 people with depression can look and function quite differently because they can have a different combination of these symptoms and still have that criteria of meeting a major depressive episode. So it can be significant weight loss or gain, insomnia, where they have difficulty falling asleep or staying asleep, they wake up regularly, or hypersomnia, where the person is sleeping a lot. And so often what you'll see is that people who have significant weight loss, they might tend to be the type of person that is not sleeping as much and have agitation, psychomotor agitation, whereas people that gain weight tend to be also clusters together with hypersomnia, where they sleep quite a bit, and they have fatigue as well. Psychomotor agitation can refer to things like pacing up and down. That would be a form of psychomotor agitation. Retardation is sort of a slowing, so people might move quite slowly if they have depression. Also feelings of worthlessness or excessive or inappropriate guilt. Maybe they're apologising all of the time, apologising for their existence even. They have that little sense of self-worth. And also, along with that, they might have diminished capacity to concentrate and also have indecisiveness, so not able to, to decide between options as well. And so the possibility, the last symptom there is recurrent thoughts about death or suicidality. And so the suicidality can range along quite a spectrum, which is what you're assessing when you have your suicide risk assessment as well, in terms of whether it's passive suicidal ideation, so things like, I might be better off dead. That would be passive suicidal ideation versus active suicidal ideation, where they have plan and intent and also means to undertake the plan that they have. So I describe that because there's ranges within each of these symptoms, and there's also a range of symptoms. So you can begin to see actually why people with depression present quite differently across the board. And the other piece of this, which separates this from maybe just sadness versus now it's meeting criteria, it really has to cause clinically significant, or other words, meaningful distress to the person, or if they're not distressed by it, it at least has to be impairing their function. And as we described before, one of the rule-outs is that it's not attributed, these symptoms are not attributed to substance use, like alcohol, for example, or some other medical condition. One thing I will say, you might have heard the word anhedonia before. That really applies to this number 2, so diminished interest or reduced pleasure in activities that were previously pleasurable. If you're wondering what anhedonia means, that basically applies to number 2 here. Questions about that? Okay, so the other piece, what you'll be covering in your tutorials as well, is about the various specifiers that you add to your diagnosis. And so here with depression, you're referring to the most recent episode, because people tend to, depression often tends to be a cyclic disorder where you have a number of episodes. And so with the specifiers, you add the specifier to the most recent episode that the person is describing. So ratings of severity, whether there's psychotic features present, whether there's anxious distress or otherwise mixed features. So there's a number of different specifiers that you can add with catatonia or with postpartum onset, seasonal patterns. And so really these specifiers are not essential, they're not mandatory that you add. For your assignment you need to have them because basically these specifiers really provide much more information, so a richness of the diagnosis. So if you recall back in one of our earlier lectures, one of the noted disadvantages of the DSM is that we sometimes have a loss of information because, you put a diagnosis on and then you lose all of the detail about the symptoms with that. So specifiers are a way to add to the diagnosis another level of information. So rather than just major depressive episode, this gives a little bit more detail about how that person is presenting and what types of problems that person might be experiencing, with the idea that that then further informs our treatment approach. So these are some of the differential diagnoses in a little bit more detail. There's a couple of seats down the front here, if you would like to come down here. And so with some of the medical conditions that you would like to rule out, so certainly neurological problems, so Parkinson's disease, if there's any type of dementing illness, epilepsy, stroke, tumours, a number of medical conditions can influence or even underlie the presentation of symptoms of depression. Certainly, illicit or prescription drugs can also contribute to some of these symptoms. And so when you're looking at a diagnosis, you always want to be looking at sort of a holistic picture about what other things might be contributing towards this person's presentation. And also if there's other disorders, if there's bipolar disorder that might be present as well. A lot of people who have depression, people will present because the depression is problematic, but the manic or the hypomanic episode is actually quite enjoyable, so people don't necessarily present for treatment during those times, and so a lot of people who have depression might actually be better assigned a bipolar disorder. So it's all about gaining the information that you need to have the accurate diagnosis, because again, that has ramifications for treatment, which we'll be discussing today as well. So in terms of